So ito yung conceptual depiction of the cell cycle. Okay? All of the cells, either normal or neoplastic cells, will traverse the cell cycle. Okay? So about 40% is spent by the tumor cells in the G1 phase. Yung G1 phase, ito yung synthesis of the cell components that are needed for the DNA synthesis will happen. Okay? And about 39% is spent by the tumor cells in the S phase or the DNA synthesis phase. Okay? It is where the replication of the DNA gene, and about 19% is spent by the tumor cells in the G2 phase, wherein synthesis of the cellular components for mitosis happens, and only about 2% is spent by the tumor cells in the mitosis. So lahat ng G1 to M phase, yung cell cycle specific drugs or chemotherapeutic drugs, dun siya nag-e-effect. Well, for the cell cycle non-specific, kahit nasa G0 or resting phase yung tumor cells, pwede siyang mag-effect. Okay? We have also the growth fraction, which is the proportion of cells in a tumor population that are actively dividing. Okay? And the rescue therapy, the administration of endogenous metabolites to counteract the effects of anti-cancer drugs or on normal cells. Ang mga siguro nakausap na kayo ng mga may nakausap na kayo na undergoing chemotherapy, nakita niyo na yung mga side effects ng chemotherapy, no? Meron na kayong na-encounter na gano'n. Parang tinatanong niyo din kung nakailang cycle na kayo ng chemotherapy. Kasi may mga, when we say cycles, mga 6 cycles chemotherapy, especially for breast cancer, yan yung mga terms na ginagamit doon. Okay? So anti-cancer drugs are grouped according to their actions on the tumor cells. They may act on the DNA through damage of the DNA or inhibit the synthesis or functions. Pag nag-damage sila ng DNA, it's either they will alkylate the DNA strand or formation of free radicals. They may also inhibit the synthesis or function of the DNA by formation of antimetabolites, or they inhibit the topoisomerase. Or anti-cancer drug can be categorized into their action on the mitotic spindle or their action on the steroid hormone receptors. They may be agonists or antagonists to your steroid hormone receptors. So this is the drugs under your cell cycle specific agents. We have the antimetabolites that are specific only for the synthesis phase of the cell cycle. Okay, we have also the topoisomerase 2 inhibitors, which are specific for the phase G1 and synthesis phase. We have also the topoisomerase 1 inhibitors that are specific on the phase G2 to mitosis phase, and the taxanes, binca alkaloids, antimicrotubule inhibitors, they are specific for the mitosis phase only. And we have also anti-tumor antibiotics, the bleomycin, which is specific for the phase G2 to mitosis phase. We have, under your cell cycle non-specific agents, we have the following alkylating agents. We have also the anti-tumor antibiotics, the platinum analogs, and the anthracyclines. Okay? So, except for the Burkitt's lymphoma and choriocarcinoma, na single drug lang yung ginagamit, ang ginagawa ngayon is the drug combination. So, different anti-cancer agents ang pinagko-combine to cure a specific cancer. Okay, so the role of your drug combination, it will provide a maximal kill, okay, for the cancer cells. It also provides a broader range of interaction between the drugs and the tumor cells, and it will prevent or slow the subsequent development of cellular drug resistance. Okay? So in the principles in the selection of most effective drug combination, you would consider the clinical efficacy of the drug. Okay? You also consider the toxicity that are involved sa mga different combinations of drugs. You should also consider the optimal dose of the drug, the scheduling of the drug, and even the intervals. It should be consistent intervals. Okay? You should also understand the biochemical, molecular, and pharmacokinetic mechanisms of the individual drugs in the given combinations, and the avoidance of arbitrary dose changes. Okay? So ang masad dito is yung nagkakaroon ng drug resistance, resistance ng cancer cells to your to your cancer drugs. Okay, and the following mechanisms of resistance that are involved, mayroong mga nagkakaroon ng increased DNA repair, mga tumor cells that are responsible for their resistance to your cancer drugs. Nagpo-form din sila ng trapping agents. Example is the formation of your glutathione, which interacts with the anti-cancer drugs that form reactive electrophilic species. And these are seen in alkylating agents like your bleomycin, cisplatin, and anthracycline. Okay? Mamaya sa natin, puro i-memorize mo nyo lahat mga to, mga individual drugs. Ang ginagawa namin nagdo-drawing kami ng Chemoman, if you're familiar with Chemoman. So lahat ng mga toxicities nila, mga adverse effects, draw. Mamaya papakita ko sa inyo. We have also changes in the target enzymes as a mechanism for drug resistance, especially for the target enzyme, which is the dihydrofolate reductase. Pag-increase in the synthesis of this enzyme, the dihydrofolate reductase would make your cancer cells resistant to your cancer drugs. Decrease activation of prodrugs. This is true with the purine antimetabolites and the pyrimidine antimetabolites. Nagkakaroon ng decreased activity of the tumor cells enzymes that is needed to convert your purine and pyrimidine to their cytotoxic metabolites. Inactivation also of anti-cancer drugs. This mechanism is true with your purine and pyrimidine antimetabolites and the decreased drug accumulation. There is an increased expression of your normal gene, which is the MDR1 gene for the cell surface glycoprotein. And this transport molecule, the P-glycoprotein, is involved in the accelerated efflux of many anti-cancer drugs in the resistant cells. Okay? So for the basic pharmacology of your cancer chemotherapeutic drugs, so we will discuss the following: the alkylating agents, the antimetabolites, natural product cancer chemotherapy drugs, the anti-tumor antibiotics, hormonal anti-cancer agents, and other anti-cancer drugs. Okay? So let's start first with your alkylating agents. They may, under your alkylating agents, we have nitrogen mustards, which includes your cyclophosphamide, mechlorethamine, and chlorambucil. We have also nitrosurias. Under nitrosurias, we have the carmostine and lomustine. We have also busulfan under your alkyl sulfonates. And other alkylating agents, we have the cisplatin, dicarbazine, and procarbazine. Okay. Your alkylating agents are cell cycle non-specific drugs. So they can also affect they may act on the cancer cells in the resting phase. Okay? So they form a reactive molecular species that alkylate neophilic groups on the DNA bases, particularly on the N7 position of guanine. And the result would be the cross linking of bases, abnormal base pairing, and DNA strand breakage. Resistance to your alkylating agents would occur through the increased DNA repair of the cancer cells, decreased drug permeability, or even the production of trapping agents such as your thiols. Okay? Let's go to your cyclophosphamide. Your cyclophosphamide, yung hepatic cytochrome P450 mediated biotransformation is needed for its anti-tumor activity. Okay, and one of the main breakdown products of your cyclophosphamide is the acrolein. Yung mga undergoing ng chemo na ang ginagamit is cyclophosphamide, nagkakaroon ng hemorrhagic cystitis. Reddish yung ihi, may dugo yung ihi because of the breakdown product which is acrolein. So ang ginagawa nila doon, ina-hydrate lang yung pasyente. Tapos may tinatawag na mess na binibigay sa pasyente to counteract the effect of your acrolein. Okay? Cyclophosphamide is used in non-Hodgkin's lymphoma, in breast CAs, ovarian carcinoma, and neuroblastoma. So your toxicities would include, thank you. Your toxicities of your cyclophosphamide would include GI distress, malalambot yung tae, malulusaw yung tae, even myelosuppression. So lahat ng mga nagki-chemotherapy, dapat may baseline na CBC, and after first cycle chemo, CBC uli, tinitignan yung hemoglobin. Napapansin nyo lahat ng mga nagki-chemotherapy, mababa yung hemoglobin after, okay? Because of myelosuppression. Kinakalbo din sila, okay? Because of the side effects of your different anti-cancer drugs, especially with cyclophosphamide. They are patients undergoing chemotherapy are prone to alopecia. Okay? Your hemorrhagic cystitis, which is due to the breakdown product, which is acrolein, this may be decreased by hydration and by the use of your mesna. Okay? Other toxicities of your cyclophosphamide, they can cause cardiac dysfunction. They are toxic to the pulmonary, and a syndrome of inappropriate antidiuretic hormone secretion. Okay? Your meclorethamine, they are spontaneously converted in the body to a reactive cytotoxic product. And toxicities would include a GI distress, myelosuppression and alopecia, and marked vesicant actions. Nagkakaroon ng mga butig-butig yung skin ng patient. And meclorethamine, they are best known for use in the MOPP regimen for Hodgkin's disease. Yung MOPP regimen is composed of 4 different anti-cancer drugs, which includes your meclorethamine, your vincristine or the oncobin, and the procarbazine and prednisone. Okay? Now let's go to your carmostine and lomustine. They are nitrosurias, which are highly lipophilic, so they can enter the central nervous system. Okay, so they are used as an adjunct treatment for brain tumors, and their toxicity would include your GI distress, myelosuppression, and since they can cross the blood-brain barrier and go to your CNS because of their lipophilic, they can produce CNS dysfunction. Okay? We have also cisplatin and carboplatin. These are they are given intravenously, and the drug distributes to most tissues, and they are cleared and changed by your kidneys. Okay? So your cisplatin and carboplatin, they are component regimens for testicular carcinomas and for cancers of the bladder, the lung, and the ovary. Okay? For their toxicity of your cisplatin, they can cause GI distress. They can cause mild hematotoxicity. They can also be neurotoxic and nephrotoxic. Sa neurotoxic, nagkakos sila ng peripheral neuritis, acoustic nerve damage. And the renal damage may be reduced by the use of your mannitol. So, nagda-diuresis ka, and forced hydration. While your carboplatin, it is less nephrotoxic than your cisplatin and less likely to cause acoustic nerve damage or tinnitus and hearing loss. But they have a greater myelosuppressant actions. Okay? We have also the procarbazine, which is a reactive agent that forms hydrogen peroxide, which generates free radicals that causes the DNA's transition. And they are orally active, yung procarbazine, and penetrates into most tissues, including your cerebrospinal fluid. And they are eliminated via the hepatic metabolism. Okay, so your procarbazine is also a component of your MOPP regimen for Hodgkin's. And their toxicity would include your myelosuppression, GI irritation, CNS dysfunction, peripheral neuropathy, and skin reactions. Your procarbazine also inhibits many enzymes, including your monoamine oxidase, and those that are involved in the hepatic drug metabolism. They are also leukomogenic, nagkakaroon ng leukopenia after use of procarbazine, and they can cause also disulfiram-like reactions that occurred with ethanol. Okay. Now let's go to your other alkylating agents. We have busulfan, which is sometimes used in your chronic myelogenous leukemia. Adverse effects of using busulfan would include adrenal insufficiency, pulmonary fibrosis, and skin pigmentation. Maalala nyo yung adverse effects ng each anti-cancer drugs pag drenowing nyo sa chemoman. Like for example, yung busulfan, ang prominent na side effect niya is pulmonary fibrosis. So yung sketch lang ng chemoman, maglalagay lang kayo ng B dun sa lungs para maalala nyo. Yun yung ginagawa namin nung second year kami. Also the carbazine, which is used also in Hodgkin's disease, as part of your ABBD regimen. Your ABBD would include your adriamycin or the doxorubicin, bleomycin, vinblastine, and the carbazine. Adverse effects of your dacarbazine would include alopecia, skin rash, GI irritation, GI distress, myelosuppression, and phototoxicity and flu-like syndrome. Now let's go to your antimetabolites. They are structurally related to normal compounds that exist within the cell. So we have the methotrexate, which is antagonist for your folic acid. We have also mercaptopurine and thioguanine, which are antagonists to your purines. We have also the fluorouracil, cytarabine, cepicetabine, and gemcitabine. They are antagonists to your pyrimidines. They are cell cycle specific drugs that act primarily on the S phase or the synthesis phase of the cell cycle by interfering with the availability of the normal purine or pyrimidine nucleotide precursors through their inhibition in their synthesis, or they may compete in the DNA or RNA synthesis. Okay? So we have methotrexate, which is a substrate for an inhibitor of your dihydrofolate reductase. And this action leads to a decrease in the synthesis of your thymidylate, even purine nucleotides and amino acids, resulting to the interfering with the nucleic acid and purine metabolism. And the formation of your polyglutamate derivatives of methotrexate is the most important for the cytotoxic action of your methotrexate. Okay? Pero nagkakaroon din ng resistance ng cancer cells to your methotrexate because of the decreased drug accumulation, changes in the drug sensitivity or activity of your dihydrofolate reductase, and also decreased formation of your polyglutamates. Okay? Methotrexate are effective in choriocarcinoma, in acute leukemias, non-Hodgkin's and cutaneous T-cell lymphomas, and even breast cancers. They are also used for rheumatoid arthritis and psoriasis, and methotrexate is an abortive patient cancer drug. Common adverse effects would include your bone marrow suppression, toxic effects on your skin and the gastrointestinal mucosa. And the toxic effects may be reduced by the administration of your folinic acid or leucovorin. And this strategy is called the leucovorin rescue. The long-term use of the methotrexate will lead to hepatotoxicity, pulmonary infiltrates, and fibrosis of your lungs. And drugs that may enhance the toxicity of your methotrexate would include your salicylates, the use of non-steroidal anti-inflammatory drugs, use of sulfonamides and sulfonylureas. We have mercaptopurine or your 6-MP and the thioguanine or your 6-TG. They are purine antimetabolites, and both drugs are activated by your hypoxanthine guanase phosphoribosyl transferases to toxic nucleotides that will inhibit several enzymes that are involved in purine metabolism. So resistant tumor cells have decreased activity to your HGPRase, or they may increase the production of your alkaline phosphatase that will inactivate the toxic nucleotides. They have low oral bioavailability and due to forced fast metabolism by hepatic enzymes. And the metabolism of your mercaptopurine by xanthine oxidase is inhibited by allopurinol. Okay? So your mercaptopurine and thioguanine are used mainly in acute leukemias and your CML or chronic myelocytic leukemia. The main toxicity for these two drugs is bone marrow suppression, but it is dose limiting. But hepatic dysfunction like cholestasis, jaundice, and necrosis may also occur. Now we have cytarabine or the arabinose cytosine, which is a pyrimidine antimetabolite. It is activated by the kinase to RACTP, which is an inhibitor of your DNA polymerases. Of all the metabolites that are produced, the cytarabine is the most specific for the S phase of the tumor cell cycle. And resistance also may occur with the use of cytarabine. It is the result of its decreased uptake or its decreased conversion to RACTP.
Pharmacology, may tatay.
Okay, for the pharmacokinetics,
lecture dan.
It is used parenterally with slow intravenous infusion and may reach appreciable levels in the cerebrospinal fluid. And your cytarabine cytarabine is eliminated via hepatic metabolism. Cytarabine is an important component regimen in the regimen for the treatment of acute leukemias, and toxicities of this drug would include the gastrointestinal irritation and myelosuppression. And the high doses of your cytarabine lead to neurotoxicity, which includes your cerebellar dysfunction and peripheral neuritis. We have also the 5-FU, or the fluorouracil. The fluorouracil is biotransformed to 5-fluoro-2-deoxyuridine 5-monophosphate, which inhibits the thymidylate synthase and leads to thymine-less death of cells. Okay? And the resistance to fluorouracil, which include decreased activation of your fluorouracil, increased thymidylate synthase activity, and drug sensitivity of this enzyme. The fluorouracil can be given intravenously, and they are widely distributed, including into the cerebrospinal fluid, and they are eliminated mainly by metabolism. Okay? And 5-fluorouracil are used in bladder CAs, breast cancers, colon cancers, head and neck, and liver cancers, and even ovarian cancers. And they can be used topically for keratosis and superficial basal cell carcinomas. Their toxicity would include your gastrointestinal distress, myelosuppression, and alopecia is also common. Okay. Now let's go to your natural product cancer chemotherapy drugs. These drugs are derived from plants, right? And the most important of these are your binca alkaloids, which includes your vinblastine and vincristin, the phodophytotoxins, the etoposide and teniposide, and we have also the taxanes. You have the paclitaxel and docetaxel. Okay, your vinblastine and vincristin, they are spindle poisons, which by preventing the assembly of your tubulin dimers into microtubules, it will block the formation of your mitotic spindle. Okay, so they act primarily in the mitosis phase of the cancer cell cycle. Resistance to your vinblastine and vincristin may occur from increased efflux of the drugs from tumor cells via the membrane drug transporters. Okay? So both drugs, your vinblastine and vincristin, must be given parenterally, and they penetrate most tissues except the cerebrospinal fluid. And both drugs are cleared mainly via biliary excretion. Okay? So vincristin is a component of your MOPP and COP regimen, which is used in acute leukemias, lymphomas, Wilms tumor, and choriocarcinoma. While your vinblastine is a component of your ABBD regimen for Hodgkin's lymphoma. And it is used for other lymphomas like neuroblastoma, testicular carcinoma, and Kaposi's sarcoma. Okay? So for your vinblastine, it can cause gastrointestinal distress, nagkakalbo yung pasyente, and bone marrow suppression. While vincristin does not cause serious myelosuppression, but they have neurotoxic actions and may cause areflexia, peripheral neuritis, and paralytic illness. Meron kaming kapitbahay noon yung ito yung parang ano yata siya, cancer, bone cancer siya. Pero ang ano niya palagi niyang complain sa akin is paralytic illness. Hindi na siya tumatay for 5 days. So kailangan palaging may suppository. Yan. And after every chemotherapy, laging 60 plus, 70 plus na lang yung hemoglobin. We have also etoposides and teniposides, which is derived from the from the plant Podophyllum peltatum. The etoposide increases the degradation of your DNA, possibly via interaction with your topoisomerase 2, and also inhibits the mitochondrial electron transport. And this drug is specific for or most active in the late synthesis phase and the early G2 phase of the cell cycle. The tiniposide is an analog of your etoposide, and they have also similar pharmacologic characteristics. So they are well absorbed after oral administration, and they are widely distributed to most body tissues. And they are eliminated mainly via the kidneys, and those reductions should be made in patients with renal impairment. Pag nag-start yung mga chemotherapy, kailangan ding tinitignan yung blood chem, baseline blood chem of patients. Kasi tinitignan mo yung functioning of your kidneys, the functioning of your liver, kasi sila yung mag-metabolize and mag-eliminate sa mga cancer drugs na bibigay niya sa pasyente. Okay? Your etoposides and tiniposides are used in combination drug regimens for the therapy of your small cell lung carcinoma, prostate CAs, and testicular carcinomas. And the toxicities would include gastrointestinal irritation. It can also cause alopecia and bone marrow suppression. Okay? Now we have the paclitaxel and the docetaxel. They are derived from the bark of these plants. They are spindle poisons and act differently from your bean alkaloids, which they prevent the microtubule disassembly into tubulin. Okay? And these drugs are given intravenously. Okay? The taxanes are used in advanced breast CAs and ovarian cancers. Okay? The toxicity of your paclitaxel would include neutropenia, thrombocytopenia, high incidence of peripheral neuropathy, and possible hypersensitivity reactions during infusions of this drug. While your docetaxel causes neurotoxicity and bone marrow depression. Let's go to your anti-tumor antibiotics. They are made up of several structurally dissimilar agents, including your doxorubicin, daunorubicin, your bleomycin, dactinomycin, metamycin, and metramycin. Okay? Your doxorubicin and daunorubicin, these are anthracyclines that can intercalate between your base pairs. They can inhibit the topoisomerase 2 and generate free radicals. So they block the synthesis of your RNA and DNA synthesis and causes the DNA transition. Okay? The membrane disruption may also occur, and these doxorubicin and daunorubicin are the cell cycle non-specific drugs. They must be given intravenously, and they are metabolized in the liver, and the products are excreted in the bile and in the urine. So the red color is not hematuria upon using doxorubicin and daunorubicin, unlike yung nagkakaroon ng acrolein. Okay? Doxorubicin is a component of your ABBD regimen, and they are used in the treatment of Hodgkin's lymphoma, and also used in the treatment of myelomas, sarcomas, breast CA, endometrial CA, lung cancers, ovarian cancers, and thyroid cancers. But the main use of your daunorubicin is the treatment of acute leukemias. Okay? Idarubicin is a new anthracycline that is used, and this is approved for the use in acute myelogenous leukemia. So both drugs can cause bone marrow suppression, gastrointestinal distress, and severe alopecia. Their most distinctive adverse effect is cardiotoxicity, which includes initial electrocardiographic abnormalities possibly arrhythmias, and developing cardiomyopathy and congestive heart failure. Okay? Maalala nyo na yan, yung letter D, basta doxorubicin, daunorubicin, puso. Pag tapatin nyo lang opposite yung dalawang D para maging puso. Ayan yung mga ginagawa namin. We have also the dexrazoxane is a free radical scavenger which may protect against cardiotoxicity. The liposomal formulations of your doxorubicin is less cardiotoxic. We have also bleomycin, the mixture of glycopeptides that generates the free radicals which binds to the DNA strand, causes them to break and inhibit the DNA synthesis. These are cell cycle specific drugs that are active in the G2 phase of the tumor cell cycle. And bleomycin must be given parenterally, and it is inactivated by your tissue aminopeptidase, but some renal clearance of intact drug may also occur. So bleomycin is a drug regimen. It is a component of the drug regimen for Hodgkin's disease and testicular cancers. It is also used for the treatment of lymphomas and for squamous cell carcinomas. The toxicity profile of your bleomycin sa lungs naman to would include pulmonary dysfunction, like formation of pneumonitis and nagiging fibrotic yung lung, which develops slowly and it is dose limiting. Hypersensitivity reactions can also occur, and also mucocutaneous reactions like alopecia, blister formation, and hyperkeratosis. Dactinomycin is a cell cycle non-specific drug that binds to double-stranded DNA and inhibits the DNA-dependent RNA synthesis. They must be given parenterally, and both intact drug and metabolites are excreted in the bile. Okay? So they are used in melanomas and Wilms tumor. The toxicity of your dactinomycin would include bone marrow suppression, skin reactions, and gastrointestinal irritation. Metomycin is also a cell cycle non-specific drug that is metabolized by the liver enzymes to form an alkylating agent which cross-links the DNA. It is given intravenously with a rapid clearance by your hepatic metabolism, and they act against hypoxic tumor cells and in use in combination regimens for adenocarcinomas of the cervix, of the stomach, the pancreas, and the lung. Okay? Toxicities of your mitomycin would include severe myelosuppression, and it is toxic to your heart, the liver, lungs, and kidneys. We have also hormonal anti-cancer drugs. So we have glucocorticoids. Under your glucocorticoids, ito yung kasali sa mga regimen. There's always prednisone. And it is the most commonly used glucocorticoid in the cancer chemotherapy. The steroid has an applications in drug regimens for acute and chronic lymphocytic leukemias, in the MOPP regimen for Hodgkin's disease and other lymphomas. Okay? We have also the sex hormones. We have the estrogens, the progestins, and androgens, which are used in some hormone-dependent cancers to change the hormone balance. The floximesterone, which is an androgenic steroid, may be used in women with advanced breast CAs. We have also the estrogenic steroids. Sample is your diethylstilbestrol, which is a pill, sometimes used in men for prostate carcinomas. Okay? Your tamoxifen, an estrogen receptor partial agonist that block the binding of their estrogen to receptors of estrogen-sensitive cancer cells in the breast tissues. So this drug is used in the receptor-positive breast CAs and may have a preventive effect in women in high risk of breast CAs. Okay? They have an activity in progestin-resistant endometrial carcinomas, but may also activate estrogen receptors in the endometrial cells that to cause hyperplasia and neoplasia. And the toxicity of your tamoxifen causes nausea and vomiting, kakaroon ng hot flashes, vaginal bleeding, hypercalcemia, ocular dysfunction, and also peripheral edema. We have also the toriamifin, which is a newer estrogen receptor antagonist that is used in advanced breast cancers. The flutamide, which is an androgen receptor antagonist that is used in your prostatic carcinomas. And adverse effects of your flutamide would include gynecomastia, hot flashes, and even hepatic dysfunctions. We have also the gonadotropin releasing hormone analogs. This includes your leucoprolide, goserelin, and nafarilin. Okay? They inhibit the release of your pituitary luteinizing hormones and follicle stimulating hormones. And these agents are as effective as diacylvestrol in prostate carcinomas and causes fewer adverse effects. Your leuprolide may cause bone pain, gynecomastia, hematuria, impotence, and testicular atrophy. We have also aromatase inhibitors. We have the anastrozole and letrozole, which inhibits aromatase, the enzyme that catalyzes the conversion of your androstenedione, which is an androgenic precursor to estrone and an estrogenic hormone. And these both drugs are used in advanced breast CAs. And toxicities of your aromatase inhibitors includes your nausea, diarrhea, hot flashes, bone and back pain, and peripheral edema. Let's go to your miscellaneous anti-cancer agents. We have the asparaginase. It is an enzyme that depletes the serum asparagine, and it is used in the treatment of the T-cell autotrophic cancers like your leukemia and lymphomas that require exogenous asparagine for growth. So asparagine is given intravenously and may cause severe hypersensitivity reactions, acute pancreatitis, and even bleeding. We have the metosantrone, which this anthracene compound probably acts by the alkylation of the bases, and it is used in combination regimens for refractory acute leukemias and in breast carcinomas. So toxicities of your metosantrone would include myelosuppression, gastrointestinal effects, and cardiac arrhythmias also. Cardiac arrhythmias may also occur. We have the interferons. These are endogenous glycoproteins with antineoplastic, immunosuppressive, and antiviral actions. Your alpha interferons are effective against a number of neoplasms, including your hairy cell-like leukemias, early stage of chronic myelogenous leukemias, and T-cell lymphomas. And the toxic effects of interferons would include myelosuppression and neurologic dysfunctions. Okay. We have monoclonal antibodies, the rituximab, which is a monoclonal antibody to a surface protein in non-Hodgkin's lymphoma cells. And they are presently used with conventional anti-cancer drugs, including your example is your cyclophosphamide plus vincristine plus prednisone in low-grade lymphomas. And they are associated with hypersensitivity reactions and myelosuppressions. We have also trastuzumab, which is a monoclonal antibody to a surface protein in breast cancers that overexpresses the protein HER2. Okay? Acute toxicity of both trastuzumab and rituximab includes nausea and vomiting, chills, nagkakaroon ng fever yung pasyente and even headache. Okay? Your trastuzumab may cause cardiac dysfunctions, including congestive heart failure. For strategies in cancer chemotherapy, we have, natapos na natin to, combination chemotherapy, even the principles, the roles, and for the combination chemotherapy. Yung Hodgkin's disease, may dalawang combinations yung ginagamit. Pwedeng MOPP regimen or your ABBD regimen. Okay? So your MOPP regimen would include the following anti-cancer drugs, and it is effective and was the mainstay of drug treatment for stages 3 and 4 of the disease for many years, but it is now replaced with the ABBD regimen. And this is composed of adriamycin, bleomycin, vinblastine, and difarbazine. They are usually effective and appears to be less likely than the MOPP regimen to cause sterility to patients and secondary malignancies like leukemias. And if the neoplasm becomes resistant to the ABBD regimen, then you can always go back to your MOPP regimen. Okay. For the non-Hodgkin's lymphoma, you can use the COP regimen, which includes your cyclophosphamide, oncobin, and prednisone. And they are commonly used with or without your doxorubicin. For testicular carcinomas, you can use PBB regimen, which includes your platinol and platinol, which includes your cisplatin, vinblastine, and bleomycin, which is the original treatment. But now, ang ginagamit na is your PEB regimen. The vinblastine is replaced by your etoposide. It is now considered the first-line treatment, and it is equally effective and better tolerated. For breast carcinomas, we can use different regimens. We have the CMF regimen, which is composed of your cyclophosphamide, methotrexate, and fluorouracil with or without tamoxifen. And they can also be used for post-operative chemotherapy. Your CEF regimen, it's composed of your doxorubicin, the cyclophosphamide, and the fluorouracil. Okay? And the FEC regimen is composed of your fluorouracil, epirubicin, and cyclophosphamide. For the breast carcinomas, tamoxifen is added to regimens for receptor-positive cancers, while trastuzumab may be included if tumors overexpresses the HER2 protein. Additional strategies for cancer chemotherapy, we have the pulse therapy, which involves the intermittent treatment with very high doses of your anti-cancer drugs. The doses that are too toxic to be used continuously. Yung parang hindi cycle pa rin siya, pero konti-konti lang yung dose na binibigay. So it is an intensive drug treatment every 3 to 4 weeks, which allows for maximum effects in plastic cells with hematologic and immunologic recovery between courses. And this type of regimen is used successfully in the treatment of acute leukemias, testicular carcinomas, and Wilms tumor. We have also the strategy of recruitment and synchrony. It involves the initial use of a cell cycle non-specific drug to achieve a significant blood kill, which results in the recruitment into cell division of previously resting cells in the G0 phase of the cell cycle. And with subsequent administration of your cell cycle specific drug that is active against the dividing cells, maximal cell kill may be achieved. And a similar approach involves synchrony in the use of your beta alkaloids to hold cancer cells in the mitotic phase. Subsequent treatment with another cell cycle specific drug such as your S-phase specific agent, the cytarabine, may result in the greater killing effect of the neoplastic cell population. We have also the rescue therapy. So toxic effects of your anti-cancer drugs can sometimes be alleviated by using your rescue strategy. Example, when you use high doses of methotrexate, this can be given for 36 to 48 hours and terminated before severe toxicity occurs to cells in the GI tract or in the bone marrow. Leucovorin, or the 4-mil tetrahydrofolate, which is accumulated more readily by the normal than the neoplastic cells, is administered, and this result in the rescue of your normal cells. Okay? Because leucovorin bypasses the hydrofolate reductase step in the folic acid synthesis. We have also the MESNA, or the mercaptoethanosulfonate, which traps the acrolein that is released from as a metabolite of cyclophosphamide. It reduces the incidence of your hemorrhagic cystitis. Okay? We have also the dexamethasone, which is a free radical trapper that affords protection against cardiac toxicity of your doxorubicin. Okay? So this is the chemoman. Okay? Madali lang, ayan, para ma-memorize nyo lahat ng mga side effects, pati yung mga functions of your anti-cancer drugs. So si vincristine and vinblastine, they are prominent for their in their CNS effects. It causes a headache, nilalagay dun sa taas. Your doxorubicin, which causes alopecia, kaya nandun. We have also the cardiotoxic anti-tumor antibiotics. We have the daunorubicin, kaya letter D. The bleomycin, which causes pulmonary fibrosis. And the methotrexate, which is an antimetabolite that causes liver toxicity. We have also an alkylating agent, the cisplatin, which is nephrotoxic. And the cyclophosphamide, letter C, which releases the acrolein as a metabolic product. It causes hemorrhagic cystitis. And we have also the antimetabolite, which is a cytarabine, which can cause muscle pains, body malaise, and fever. Pwede nyo pa rin supplementary reading sa next di ba may 2 hours pa kayo na available. Pwede kayong mag-ano pa dun sa Katsung, yung mga hindi nasali dito sa natin, sa lecture natin. Mag-attendance muna. Ano to? Ay, wow. Ay, oo.